Welcome to the LACNETS podcast. I'm your host, Lisa Yen. I'm the LACNETS Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. Welcome to the LACNETS podcast. I'm really excited to introduce our guest for today, Dr. Riham El Khouli. Dr. El Khouli is the Director of the Radiotheranostics Program and the Chief of the Division of Nuclear Medicine at the University of Kentucky, and the Associate Professor of Radiology, Nuclear Medicine, and Molecular Imaging at the UK School of Medicine. The Radiotheranostics Program at UK is a multidisciplinary program, and it provides state-of-the-art standard of care clinical radiopharmaceutical therapy, or PRRT, as well as robust research program that constantly runs multiple PRRT clinical trials aiming at exploring new options for various cancers, including neuroendocrine cancer. Dr. El Khouli is a fellowship-trained, double-board certified radiologist and nuclear medicine physician with 2 decades of clinical and research experience. She is clearly passionate about research and education, and she's active in the field of neuroendocrine tumor. She is one of the key team members of a dedicated biweekly NET tumor board, and she's presented at multiple NANETS regional meetings, and I had the pleasure of meeting her at one of the first post-COVID NANETS meetings in Lexington at the UK Markey Cancer Center about 2 years ago in April 2022. I really appreciated her passion for what she does and the clear way she explains things, especially this field of PRRT. So we're really excited to have Dr. El Khouli join us today to discuss the hot topic of PRRT. And before I allow her to introduce herself, I just wanted to share the fun fact that she not only loves traveling, she really loves watching different TV shows from around the world. And that includes TV shows from Turkey, the Philippines, Brazil, Italy, just to name a few. And what she enjoys is learning about other cultures, foods, and landscapes, and has even picked up little bits of the language along the way. So Dr. El Khouli, welcome to the LACNETS podcast. We're really happy to have you. And if you could, just share a little bit about yourself and how you got involved in the NET world.
Thank you so much, Lisa. It's really, really great to see you again. I remember when we met first time in Lexington. It was a great meeting, and I met a lot of lovely people, and I really enjoyed it a lot. And I enjoy NET. It's a rare disease, yet it's indolent disease. Because of that, patients luckily survive for a long time. They are the most intellectual patients about their disease. This is what always has been my observation. I was lucky, I have to say, that when I moved to Lexington in 2016 and joined the team here, Dr. Anthony is one of the experts in neuroendocrine tumor in the nation. And as you know, in different places in the country, people are not lucky to have experts. There are very few experts around the country. In most places, neuroendocrine tumor patients are managed by GI oncologists just because of the rarity of the disease, nothing else. But in few sites like here in Lexington, we have experts where a lot of the neuroendocrine tumors would come from all around the country for our centers. So when I came here, my interest in neuroendocrine tumors started, and I joined the team here, and my passion toward neuroendocrine tumors started. And it was that year when actually gallium-68 dotatate was FDA approved. And this is why I say I was lucky, because it just coincided with that time. And I am a radiologist, a nuclear radiologist. We became one of the very few centers around the country that started right away offering gallium-68 dotatate. And I want to tell you that I'm proud to say that UK was the number 1 site volume-wise doing gallium-68 dotatate. Because of the team. Dr. Anthony, of course, and Aman Chauhan here, Dr. Anthony was the key reason why we had such a huge volume. We had the best combination, a passionate medical oncologist with a passionate nuclear physician. So the best team, like we both love the neuroendocrine tumor patients, and we both are very enthusiastic and a big believer of the modality, the radiopharmaceutical. It was amazing. It was revolutionary. We better assess the disease. So we had a lot of patients coming through our center with the gallium-68 dotatate. And then, of course, we started doing more research. We started going to more conferences, and we had other trials happening here. And since then, of course, we had the neuroendocrine tumor board, which happens every 2 weeks. We see 12 patients. It takes me a lot of time to prepare the cases. So I can't prepare more than 12 patients for each tumor board. So we had to limit them. Honestly, neuroendocrine tumor patients are usually discussed in the GI tumor board. But for us, we have a dedicated neuroendocrine tumor board. So I am lucky to be part of the team here in the University of Kentucky, definitely.
And they're lucky to have you. I remember the FDA approval, right, in 2016, and it's been 8 years, and it's amazing how things have changed during that time.
It was amazing. It was revolutionary for us. Till that time, FDG was basically the main and the only radiopharmaceutical for pets. We were just doing FDG. That's it. Now, you can't say that. You have to say which radiopharmaceutical because we have multiple. The IM68 DOTA was the start of that era. Then we started saying, okay, you cannot say PET-CT anymore. You have to tell me which radiopharmaceutical you want to do because I have two now. So it was revolutionary. It was a game changer. DOTA changed our life.
And on the patient front, as a caregiver myself, I can say it changed our lives too. It really was a game changer, revolutionary. What a good point that you're making, that it used to be. And even nowadays, we still hear people say, I got a PET-CT. And like you're saying, now it's which PET-CT?
I still till now get requests saying PET-CT, and my scheduler calls me and say, hey, Dr. Khouli, I have this request. I don't know what to do with it. I say, well, I'm sorry, we have to call the provider. And sometimes it doesn't have like outside request and it doesn't have any history or anything. And even like for neuroendocrine tumor, a lot of times we need dual tracers. Some patients need both FDG and DOTA. So even if I know that this patient has a grade 2 differentiated neuroendocrine tumor, sometimes I need to know what is the clinical question. What are we looking for? So do we really need to do DOTA or do we need to do FDG? Some patients, we have both of them done. So PET-CT is not enough anymore. And a lot of providers now understand that. And luckily, they know to put the right radiopharmaceutical in the requisition. I'm not going to say the DOTA, I'm going to say the neuroendocrine tumor patients changed our life.
Patients do change things. And thank you for how you change this field, because this is a key takeaway point right here about PET-CT. It used to be just one, and now it's which PET-CT. And we really have to define that. And perhaps it's a perfect lead into this whole topic of PRRT. We threw out some terms, even as I was sharing a little bit about you and your background: radiotheranostics, radiopharmaceutical, radioligand therapy, PRRT, Lutathera. What is this field? Could you explain what it's all about and how it works?
Absolutely. It's my pleasure. So PRRT first. Believe me, a fun fact about me, I hate acronyms. A lot of people use acronyms and they think everybody understands them. Even in medical records, a lot of doctors use acronyms and they think that I should understand these. I keep using Google because I don't get what the heck is this? What does that mean? Why do you think that it's intuitive to me because it's intuitive to you? It doesn't have to be. I mean, I'm sorry, but I don't understand all the acronyms. So I like to spell things out because there are maybe few internationally known acronyms like maybe ml, milliliter, maybe. Like the big ones that everyone in the world knows, maybe. But really, acronyms, I hate them. So PRRT. PRRT means peptide receptor radionuclide therapy. Peptide means protein. Receptors because it is receptor-based. Radionuclide therapy because it is going to be radioactive that is come from the radionuclide in the nucleus, will bind to the receptor. They decided to call it that to make it unique to this specific therapy to differentiate from the prior radioactive therapy that we used to get. So it's called PRRT. Just for you to know what does that mean. And you don't have to really think again about it as a patient, but just to know what it means. What you need to know also, what PRRT scientifically is. It's lutetium-177 DOTA. They are two parts. The lutetium-177, which is the radioactive part, and the DOTA, which is the somatostatin analog, which binds to the receptor. So this is the receptor that is specific to neuroendocrine tumor. It's receptor that is expressed on the neuroendocrine tumor. And the lutetium-177 is the radioactive part that hooks to that receptor. And this is the therapeutic one. It emits beta particles. that will treat your tumor. This dotatate, this somatostatin analog, similar to gallium-68 dotatate. It's the same one. We can label it with gallium-68, which is another radioactive isotope, but this time it's imaging only because it's a positron emitter. I use it for PET imaging. So this brings us to another term you will hear a lot, which is theranostics. What is theranostics? It's basically two pieces we stuck together. Thera, which is the first part of the word therapy, and gnostics, which is the end of diagnostics. Theranostics. Why do we do that? Because we marry the diagnostics and therapeutic together. Why is that? You have dotatate, which is the target part, which is the somatostatin analog, which is molecule that goes and binds to the receptor, which is on the cell membrane of the neuroendocrine tumor. That molecule, we can radiolabel it with radioisotope that is diagnostic only, which is the gallium-68 or copper-64, and we image with PET-CT. Then we see where the tumor distributes in your body. So basically, we know ahead of time what are we targeting, or do you have enough expression of the receptors to be eligible for our treatment. Then the same target, the same dotatate or the somatostatin analog, we radiolabel it with lutetium-177, which is a beta emitter, which is a therapeutic radioisotope. But then we are treating knowing where exactly this molecule going, because this is the same exact biological target. This is the beauty of radiotheranostics. Previously, we would treat, and then after treating, we know what happened. But now we actually know what will happen before we treat, because we know, is this patient eligible or not? Does he have the receptor expression or not? There are other factors that affect the efficacy of treatment, but at least we know that the receptors are there, that the treatment we're giving is going to bind to these receptors because they exist. So this is what PRRT means.
That's a really thorough overview. You said so many important things. This is the same receptors that's targeted with the imaging and then also therapy, so that we're at theranostics, and that you know before going in who's eligible, who it might work for. So how do you know who's eligible? You hinted that there's a certain amount of uptake that you're looking for. What kind of uptake are you looking for?
So we have to do the PET-CT first. We do the gallium-68 or the copper-64, dotatate or dotanoc as well. But the idea is it's somatostatin analog that show me the receptor expression. And we do the imaging. Usually we like internal reference. So our internal reference is the liver. We look at the liver uptake, and then we look at the lesions and we see, is it above the liver, which is our normal reference, or not? If it's more than the liver, which is most of the time, then we say, okay, this patient is eligible. We have enough uptake that when we give the treatment, they will have enough uptake to get enough treatment effect. So it's worth getting radiation, because this treatment will have radiation. So we don't want you to get radiation without getting any benefit from that. And actually with PET-CT, we can quantify. There's quantification with PET-CT. So we do the PET-CT first. Nobody can give lutetium-177 dotatate without doing a PET-CT. It's a must. So who are the patients that we do these scans for? This is what's FDA approved. Grade 1 and grade 2 giblets, the GI and pancreatic and neuroendocrine tumors, well-differentiated, low-grade and neuroendocrine tumors of the gastrointestinal and pancreatic origin. We were approved as a third-line treatment. Basically, patients with metastatic disease, progressive disease, usually they are not surgical candidates. The regular somatostatin analog failed to improve the patient's symptoms, then PRRT comes in. This is right now the standard of care. I think we are in the stage now that we are very close to expanding the indication for PRRT, because I know that there are already clinical trials that we are involved in having the Lutathera for first-line treatment. And I know that the results are very, very promising. They are even better than the third line. So we think that hopefully soon it will be expanded as a first-line treatment.
And when we say first line, when is that? Is that even before surgery? Is that after surgery, but before the shots, the monthly somatostatin analog?
Well, it depends. I mean, it should not preclude surgery. I mean, if there is a surgical option for the patient, definitely surgical option is number one. Nobody can argue with that. But once surgery happens, if there's residual disease and patients not candidate for surgery anymore, PRRT can be a good option. Right now, it's not. We are approved as a third line. Metastatic progressive disease is where we come and play. So usually what we see is patients with metastatic advanced disease. This is when we are in play. A lot of our patients have diffuse metastatic disease when they come to get PRRT. The trials are in lower volume disease early on. I think the results are very promising, and hopefully at some point we move early on. We have other diseases that radiopharmaceutical therapy is in the upfront just after surgery, like thyroid cancer. We do surgery and then radioactive I-131 is done upfront.
Yeah, so doing it earlier instead of waiting later, maybe with smaller volume disease, maybe with different types of NET, even higher grade and other types as well.
We are involved in trials with small cell, even carcinoma. Some of them expresses somatostatin analogs, and we have active trials right now we are involved in that we give PRRT for these cancers. The grade 3 poorly differentiated small cell cancer. We don't know the results yet, but there are active trials. But of course, you do the dotatate first to prove expression of the receptors, and then we give the PRRT. The basic teaching is what? Basic teaching is that the grade 3 poorly differentiated carcinoma do not express the receptors, but no, some of them do express some of the receptors. And these patients, right now, there's a trial that we give them PRRT. This is an active trial that we are involved in, and we are recruiting patients. It's a multi-center trial. So I don't know what are the results going to end up. Are we effective? We don't know. I am very curious to see what are the results of this trial.
Yeah, that's really interesting. So you're mentioning other types of NETs outside of GI and pancreas, possibly other lungs. I know that there's that trial open as well.
There are trials in all and combination therapy, for example. So what does PRRT does? It causes DNA break, but then the body has mechanisms to repair the DNA break. So there are drugs to deactivate one of these mechanisms that repairs the DNA break. So if we give the PRRT with a drug that deactivates the repair mechanism, that will potentiate the effect, what we call synergism. It will make the PRRT effect even more potent. So there are studies with that, clinical trials that give the PRRT or any radiopharmaceutical therapy with what we call radiosensitizers. And there are other studies with radiopharmaceutical therapy with other chemotherapy or immunotherapies. Also, there are other clinical trials with alpha emitters. Lutetium-177 is the beta emitter. Beta emitter is like a tennis ball. Alpha emitter is like a cannonball. See the difference between a tennis ball and a cannonball? A cannonball is huge, with a huge destruction. Also, it's heavy. It will move very slow distance. So actually, this will mean that it will cause less side effects. So now we are involved in multiple trials with alpha emitters as well. So there are so many clinical trials right now going on with so many different targets. And not only dotatate, there are many other trials with different targets.
That's really exciting. We have to define which PET scan you're talking about now, and in the future, we're going to have to define what kind of PRRT as well.
Right now, a lot of directions to alpha emitters. We're trying to do alpha emission, which is more destruction, which means more toxic effects to the tumor and the neighboring cells, of course, and hopefully less side effects than beta emitters, because beta emitters have longer distance than alpha emitters. Think of them just for comparison, a tennis ball and a cannonball. So there's a lot of clinical trials right now testing alpha emitters.
Well, that's really exciting. And we'll circle back to the topic of alpha because I know that's really interesting to many. But this is a good time to ask. The next question would be, how does PRRT differ from other treatments? I mean, even that mention of radiation, how does it differ from other radiation treatments that people use for other cancers and just other treatments that are out there for neuroendocrine tumor?
So let's talk first about radiopharmaceutical therapy treatment versus non-radiopharmaceutical therapy. When we give just an analog versus radioactive, you give a treatment, it binds to the receptor, and then it internalizes into the cell and then kill the cell. But then you give a PRRT. It go to the receptor and get internalized into the cell with a DNA break. The cell is dead, but it's not that only. You can think of it as soldier that's holding a gun. It killed that cell, but he has the gun to start killing the neighboring cells because it's emitting radiation. So the radiation is not going to only kill that cell, it will kill the cells around it. So this is the difference between just binding to the receptor and killing that cell and radiolabeling that drug to have more potency and killing more cells. This is the advantage of radiopharmaceutical therapy. This is why it gives better effect. For example, the LETTER-1 trial compared the effect of adding the PRRT to the standard of care, just giving the somatostatin analog alone. And it did prove significant improvement in survival and response because of that, because of the effect not only on the cell, but on the neighboring tumor cells. So this is, of course, a difference between not only the PRRT and radiopharmaceutical therapy. And this is the direction now. Any targeted therapy is giving alone, but then you radiolabel it and you increase the effect.
We like the sound of that. So increasing the effect. And that makes me wonder, what about the side effects, especially if it's radiolabeled like that? What are the side effects of something like that?
Yeah, of course. There are some side effects. I have to talk specifically about the PRRT just because one of the main side effects of the PRRT comes with the amino acid that accompany the PRRT, which is not happening with any of the other radiopharmaceutical therapy that we give. So one of the main side effects is nausea and vomiting. And this happens mainly because of the amino acids that we infuse with the PRRT. And we give the amino acid to protect the kidneys. We usually pre-medicate the patient just before the session to control the nausea and vomiting. Actually, in our center, because we give only the lysine and arginine, which is the 2 amino acids needed, we usually don't get a lot of nausea and vomiting. But other centers might not have access to only the lysine and arginine and have to give the whole amino acid cocktail, which is available for the regular nutrition patients. And these are the ones that really suffer a lot from nausea and vomiting. We still pre-medicate our patients, but we really don't have a lot of problems. Anyway, if they give the patient a 14 amino acid cocktail, there's a lot of nausea and vomiting, and they have to pre-medicate the patients. So this is the main side effect for most patients. And this is not related to the radiopharmaceutical. What are the side effects that are related to the radiopharmaceutical therapy? The main side effects that can happen are usually the marrow suppression. How do we see that? We follow all our patients with serial blood counts. Usually the marrow suppression, if it happens, it is temporary and patients recover from it. And our treatment is 4 treatments, 2 months apart. So we give it every 8 weeks. During this time, we follow the blood labs to look for these marrow suppression, which we see by blood count drop. Most of our patients, it rebounds, which means the marrow recovers. And we don't give the next dose till we see that the marrow did recover. This is the most common. It doesn't mean it happens in all our patients, but when it happens, this is what we see. Most of our patients, when it happens, the drop in the blood counts is not that big. And it goes back again. What are the options if we saw that the drop in the blood counts got prolonged a little bit? We can delay the treatment. We don't have to give it just after 8 weeks. We can delay it more. And we can modify the dose. We can decrease the dose next time and see if the effect is not the same. We always have options. Of course, at some point, if we didn't feel that the patient recovered, we can stop. The platelets and the neutrophils and the hemoglobin are the 3 that we look at. Then the next one is, of course, the renal functions and the liver functions. They are not as affected as the blood counts. The blood counts are the most that we care about, but we always look at the renal functions, but really the amino acids protect it. But if the patient is coming up front with not as well renal functions, we initially usually just give them a reduced dose, just to not exhaust the kidneys and the liver functions as well. If we feel that the liver functions are not as well, we reduce dose. But like I said, we haven't been seeing much effect on the kidney or the liver.
That was my next question. If it's a long-lasting effect or if it's something that goes away, and if so, when do you expect it to go away?
Remember that we are indicated as a 3rd line or 4th line treatment. Patients already went through many lines of treatment before coming to us. They come to us with not normal blood counts. They already come with lower blood counts. But when we see a drop, we still want to see it coming back to the baseline. And we always have the options to delay the dose and decrease the dose. But then if we see the toxicity persistent, we stop. We don't continue because the patient's health is the most important. We can't just keep giving the patient radiopharmaceutical therapy if we feel that the marrow is affected and is not recovering.
Is there anything the patient can do or not do to help that recovery process for their bone marrow and their platelets?
No, I can't think of anything.
You mentioned the liver, and it's common for patients to wonder, especially when they have tumors in their liver, if the PRRT will affect their liver function, and if killing these tumors, is there any concern about liver failure or anything like that?
If the patient has extensive involvement of the liver, if the liver function is more than 5 times the normal, then we don't get the treatment. And this we can say sometimes, because liver is a very common site for metastasis. Almost all patients with neuroendocrine tumors, especially in these late stages where they come for PRRT, will have liver metastatic disease. If the patient have extensive involvement with like 75% replacement and the liver functions are more than 5 times the normal, then we don't give them treatment. We can't give them the treatment then because we would be concerned about liver failure. Before starting the treatment, we look at all the lab tests and we have guidelines exactly when can we treat or cannot treat. And then after starting treatment, the drop in the blood count and the liver functions and the renal functions, and we follow that. There are guidelines to that. We do imaging after doing the treatment, but I feel patients benefit the most in quality of life. Patients feel better and function better after getting the treatment, even more than I see on imaging.
That's so important. And I'm wondering, talking about quality of life, everyone always wants to know, how does PRRT affect my day-to-day function? Will I be able to work? Will I be able to get back to the things I enjoy when I'm going through the treatments?
Sure. We have a comprehensive team in the UK. When we treat somebody, not only neuroendocrine tumor and PRRT, all our radiopharmaceutical therapy treatments, we have radiation safety team work with us as well. And we have written instructions. I always tell our patients, you don't have to isolate yourself. You will never harm anyone. I even joke with them and tell them the only time you will harm anyone, I'm sorry to say, if they drink your urine. And I don't think anyone would drink your urine. I have to go to the extreme for them to understand that because I know that there is like radiation phobia. Radiation is a serious thing, but also we have to be moderate and modest about everything. I don't want the extreme in any side. They have to understand the reality about everything. So why do we give the instruction? Because the patient is benefiting from the treatment, so they get the radiation. Their family and friends and beloved ones are not getting any benefit from the treatment, so it's unnecessary for them to get any radiation. So we give them very simple instructions. If they follow these instructions, none of their beloved ones are getting any radiation. That's it. Not because they're harming them if they get radiation. They're not harming anyone. This is important to understand because people are frightened. They're not emitting radiation in any level that will harm anyone around them, even if they sit beside them. So they shouldn't isolate themselves and be miserable just because they got a treatment. It's unnecessary. They just need to be 3 feet away from people. And I even joke about it and say, well, you see, we are more lenient than COVID-19. In COVID-19 times, they told us, stay 6 feet away. We're telling you just 3 feet away. It's not that bad. And you can give everyone a brief hug. It's fine. You can give brief hugs to your beloved ones. You can eat with them. Just be on the other side of the table. You can sit with them and watch TV. If they are on one side of the sofa, be on the other side of the sofa, just 3 feet away. Time and distance are your friends. You don't want to have somebody in your lap for extended period of time. You don't want to sit and hug someone for an hour watching a movie. But you can be with them in the same room. It's fine. Just keep your distance. That's it. Keep your distance. Your sleeping partner is the most that can get radiation. So it's better to sleep in a separate bed for example, the first 3 nights. Just sleep in a separate bed. Of course, hygiene, because everything is going to be excreted in urine and feces. So you have to be cautious with your hygiene and flushing the toilet twice. And we give them a written instruction. Our radiation safety team go over the instruction with them, answer all their questions. And when we sit with them, we ask them again if you have any questions, and we give them the written instructions. And usually I tell them I would hang it on the fridge with a magnet just to have it accessible whenever something bubbles in your mind, look at it. You don't have to look for it, just have it hanging there. That's it. It's very simple. We usually have a questionnaire. Our radiation safety officers go over it with our patients to understand their living and their work and their transport situation. So, for example, if somebody works in cubicles where they are so close to their co-workers, there is a problem. But they work in offices where they have 3 feet between them and their co-workers. Yeah, of course, they can go back to work, no problem. Usually, our patients can live their life normally after treatment. There's no problem at all. And this is not only for PRRT, like thyroid cancer patients that get I-131, prostate cancer patients that get Lobecto, all our patients, the same thing. We have a questionnaire that we go over to understand their work situation, living situation, transport situation, just to find the red flags for certain patients that maybe have a special situation. Otherwise, there's no problem.
I think it's really reassuring what you said, that you're not spreading radiation. I think a common question that comes up, it's easy enough with adults to stay 3 feet away. What if you have a child or a pet that it's just too hard to keep them off your lap or away for long periods of time, and they just constantly want to be next to you or hugging you?
So let me be clear. They are emitting radiation, but not to the extent that you're harming people. So if you keep 3 feet away in the first few days, you're not harming anyone. You are not exposing anyone to unnecessary radiation. It's unnecessary for them to get any radiation from your treatment. You're not harming anyone. It's not Chernobyl here because we release them. Remember, this is an outpatient treatment. They are outpatient treatment because we know it is safe for this patient to be out to the community. Otherwise, you'd be inpatient. So it's not harmful, but it's unnecessary for his beloved ones to get any radiation. This is why we give the instruction. So kids, yeah, they can come and he can give them hugs and kiss and try to keep them away. If he knows that, let's say he has a son or a daughter or a grandson or a granddaughter that love to be in his lab all the time, he knows that there's no way I can get them off my lab, then they'll have to be in a different house. So this is an individual circumstance, it's a case specific then. But if he knows that I can reason with this kid and my wife can take the kid away, then he can stay in the house. But if he tells me, no, I'm sorry, my grandson is so attached to me, and usually he was in my lab for an hour or 2 hours, and there's no way you can get him off my lab, then I'm sorry. For the first 3 days or 4 days after the treatment, you guys have to separate the houses because this is going to expose him to unnecessary radiation. So it's going to be a discussion with the patient and understanding the situation, and then we would decide. And this is what we always do with our patients.
That's helpful.
This is what we need you to do. Can you do this? Oh, yes, I can. Oh, no, I can't. Okay, then you have to arrange for this. And sometimes we delay the treatment because he needs time to do the arrangement. And then we delay the treatment.
Yeah, that's helpful. And in terms of day-to-day life, can someone go have their PRRT treatment, Lutathera treatment, and be out in the community, grocery shopping, or going out to dinner?
Yeah, like I said, if they go to dinner, if they can keep 3 feet from everybody. You know what 3 feet is? Arm length. Just keep your arm length from everyone. You're good. No problem at all. They can live their life. We release them out of the hospital, which means they can be anywhere they want.
You're not doing harm.
They're not doing harm. We give them instruction. We go over it with them. We explain it very well. If you can keep these instructions, keep these in mind wherever you go, you're good.
As you said, this is even more lenient than COVID. And that brings up a question. Does Lutathera cause one to be immunocompromised? We were concerned about that with COVID, and there's some concern about treatments in general compromising the immune system.
Like I said, we follow the patient up and look at their blood counts, and well, maybe it brings some of the blood counts down temporarily. Maybe they transiently can be a little bit immunocompromised, but neutropenia is not one of the big problems, more thrombocytopenia. This is what we see more with Lutathera. Can it do it? Maybe. It's not immunocompromised. Can some patients get infection after Lutathera? I cannot say that it never happens. It might. Marrow suppression is the more common side effects of Lutathera. When it happens, it's transient and the marrow recovers. Can it cause the patients to get infection? It might. I cannot say it doesn't. The patient has to be cautious, and we follow the blood counts and we counsel the patient about that. Because we do follow the blood counts and we look what happens.
Yeah, so close monitoring, but it doesn't sound like there's concern for being immunocompromised in the way we normally think about it. Yeah. So you now have PRRT in the arsenal, and you mentioned that things are shifting in terms of who gets it. So how, when you're evaluating patients, how do you decide who should get PRRT?
We are FDA approved for specific indications, which is GIBNETs, well-differentiated grade 1 and grade 2. We are in the late disease only right now. Hopefully sooner than later, we will be moving earlier in the disease because I really believe that we will be more beneficial even earlier in the disease. When we target a lot of disease, it's different than when we target this disease. When do we do it? Usually they come when they did multiple line of treatments and patients progressing. How do we decide eligibility? We do PET-CT. There's expression of the receptors and there's targets. So we do Lutathera. We hope that we can have some response and we can improve the quality of life of the patients. This is how we decide on the patients. Sometimes it's used off-label, like bronchial, for example. We are not FDA approved for bronchial. Sometimes you can use it in certain institutions off-label.
Yeah. And when you look at the amount of tumor, is there a sweet spot for when to give it? And also location of tumor. Is there certain places you would or would not give it?
A lot of patients come to us have a lot of metastatic disease everywhere. We know that peritoneal disease are resistant. Patients with peritoneal disease are resistant to PRRT. If the patient, all he has is peritoneal disease, I don't prefer to give it because I know that a lot of time the response is not going to be well with peritoneal disease.
Can you explain what peritoneal disease means?
Peritoneal disease is like in the CT abdomen pelvis, there will be deposits in the paracolic gutter, in the omentum. Peritoneal carcinomatosis is this term, peritoneal carcinomatosis. Pelvic deposits, serosal deposits, these are all the terms you will hear. This is called peritoneal disease. They are deposits, it's called non-measurable disease. It's like nodules everywhere in the abdomen, scattered in the abdomen. And not only mesenteric disease, because a lot of the patients with midgut or intestinal disease will have mesenteric disease. This is fine. But some patients will have peritoneal disease. The peritoneum, it's a membrane that covers all the abdominal organs. And sometimes the disease spreads to that peritoneal coverage. And it becomes full of these nodules all around this peritoneal coverage. And then there will be fluid, ascites, with it. This disease is usually very resistant. And when we give PRRT for this peritoneal disease, patients don't respond well. We give them the radiation and there's no response. So we're giving the patients basically side effects and they're not benefiting. And the worst thing you want to do is giving patients side effects without benefit. So this is one of the things that is resistant to radiation. Other than that, a lot of patients do respond. At least quality of life is improved. Enough expression of the receptors and enough disease to treat. But most of the patients come like that. Grade 1, grade 2 always have enough expression. Grade 3 is the difference. There is grade 3 well differentiated, but they are not all the same. Some of them will have certain expression, some of them will not. So you'll be surprised. You do the PET-CT and then some of them don't have enough expression, some of them will. So it's very important to do the PET-CT for these patients.
When you say enough expression, is there a number cutoff?
I don't like numbers, but we have the reference. Liver. If you look at the reference liver, and you have to have at least above liver reference.
As long as it's above liver, that's enough. And you also talked about the response to PRRT. What kind of response do you hope for?
Well, there are two things. The quality of life, patients improve, quality of life is improving. This is acceptable response. And of course, radiographic response. We do CT and PET-CT after finishing the 4 cycles. And you will see some kind of response. Complete response is something that's hard, especially when you have somebody with massive metastatic disease, but at least some partial response. Some of the disease shrinks, a little bit shrinking. You feel that, okay, the treatment did give you some effect. Some of the size shrinks a little bit. So this is what I mean. Usually CT is what we do. If we have PET-CT that's showing you some response, that would be amazing.
Quality of life and some shrinkage. So I think that a lot of patients, when we go into treatments, what we want is a magic wand. We want it all to go away. And so you're saying it may not all go away.
In very few cases, you will see everything going away. Why? Because we so far are indicated in the late stage. If I show you some of the cases that we do, massive disease. So to really think that you can give radiopharmaceutical therapy and have all this disease done, it's very hard. This is why I'm saying I'm very optimistic. I think we will be approved for early on. Then I think we will start having these complete responses. In thyroid cancer, we give IR31 for patients for what we call ablation. We are ablating normal thyroid cells. We're not even treating disease. Because normal thyroid cells are the potential precursors for any recurrence and for also to create thyroglobulin as a biomarker, which is a blood test. But thyroid cancer is different than neuroendocrine tumor. But what I'm trying to say is when you start early, you are treating few cells, so you can take care of them. So I'm hoping that we start early on. And I'm not saying don't treat the late stage. Of course, we will still have a role in the late stage, but we want to also have an indication in the early stage. So patients who just had surgery and still have two small nodes here and there that surgeons cannot get in and start picking these tiny 3 millimeter nodes that light up in dotatate here and there. We can do PRRT for these, just one. I'm not going to do 4 cycles, 1 cycle, and maybe 50 millicurie, not 200. We have a role like that because we do this with thyroid. This is what I hope at some point we can do.
Yeah, you're dreaming of a future of giving it in different ways. So talk a little bit about how it's given right now and how many treatments and how the dosing is determined.
Right now, what we do is 4 doses, each is 200, 8 weeks apart. We have the options to decrease the dose if we have a reason. Like I said, if the patients have toxicity, like the blood counts went down, didn't rebound enough, the liver functions are not good, the kidney functions are not good, we reduce the dose to 150 or 100. How do we give it? Most of the time, an outpatient treatment. We can do it as an inpatient in certain situations. If the patient has a situation that need us to do it as an inpatient, of course we do it as an inpatient. But majority of the time, we give it as an outpatient. But the patient stay with us for almost a whole day, 6 to 8 hours, because of the amino acid. Not because of the treatment itself, it's just because of the amino acid. I'll tell you why. Because amino acid is given to protect the kidneys, because the lutetium-177 dotatate is reabsorbed in the kidney. So it would harm the kidney. So we have to give the amino acid to protect the kidney. If you look at the dotatate BCT and the F18, for example, or the gallium-68, PSMA, which is for prostate cancer, both of them you will find that the kidneys are very hot. But we don't give amino acid for the PSMA because there is no reabsorption. So it doesn't need protection. Lutathera is the only one that we give the amino acid. It's very unique because of this reabsorption. Okay, patient comes in the morning, we check them in, and then we give them the pre-medication for the nausea and vomiting, and then we start the lines and everything, and you start the amino acid. Amino acid will run at least 4 hours. This is an IV infusion. 30 minutes through the amino acid, we start Lutathera or the PRRT infusion. They run simultaneously. We don't stop the amino acid while the Lutathera is running. They go both at the same time. So the amino acid is still running while the Lutathera is running. The Lutathera runs for 30 minutes. Then the Lutathera is done. The amino acid has to run at least 3 hours after the Lutathera is done. So another 3 hours of amino acid. Then after that, the patient is done. Then we make sure that the patient is doing fine and the patient is released. So it takes the whole thing, checking in and checking out, talking to him, and all this takes not less than 6 hours. Of course, sometimes some patients have more questions or something happens. So it takes from 6 to 8 hours. So the patient is with us for a whole day, but it's an outpatient procedure. The patient is not an inpatient. He or she is an outpatient. We modify the dose based on the patient if we need to.
Yeah, so that's really helpful to understand the day and the dosing and how many treatments can be given. I'm wondering, and this comes up all the time, how many times can someone get Lutathera? And is there any maximum to the amount of PRRT one can get in a lifetime?
Right now, the standard of care is 4 doses, 2 months apart each. This is what's given. There are currently ongoing studies to look into giving them again. So we give 4 cycles and then the patient benefited from them. And let's say the patient was fine for, like, let's say 12 months or something, and the patient progressed again. Can we give the patient another 2 cycles, 4 cycles? There are ongoing studies right now looking into that. And it's promising. The results are promising. I think we will be able to give it. And there are some sites, I want to tell you, that we're doing that off-label. There are meta-analyses that showed that this is good and it's beneficial and the side effects are not that bad and there's no problem doing that. But I think it's going to be FDA approved to give Lutathera more and with some guidance to how many and what's the maximum, because there's what's called the accumulative dose. You have 200 for 4, which means the accumulative dose is 800 millicurie. Now, how many more? Because this will count into what we call the accumulative dose. How many millicuries a patient gets, because this would also affect what we think about. There's a theoretical risk always about a long-term development of cancer in 2 years, 10 years, because of how much cumulative dose, what we call a stochastic effect in radiobiology. When somebody gets a lot of radiation, in few years down the road, this might cause another cancer to develop. So this is something that they are studying right now and seeing, can we give another few cycles? How many cycles can we give? And what are the risks? So there are studies into this. But right now, the standard of care is 4 cycles, and there are promising data about repeating this again.
Yeah, hopefully we know more in the future. So you mentioned that you have alpha trials open. I know you've been studying that at your center. How do you decide which type of PRRT someone can get? And also, does getting Lutathera preclude someone from getting future alpha PRRT?
Right now, these are clinical trials, multi-center clinical trials. Each one of them have eligibility, exclusion criteria. So it always depends on the exclusion criteria. You have to run the patient through that. Is the patient eligible or not? It will depend on that. So it's not up to us. We try to get the patient into the clinical trials whenever we can. Some trials will permit, some trials will not. So it will depend on the trial, not us, because this is not standard of care. In standard of care, it's our decision, but in clinical trials, it's not.
That's a really good point. So we can't necessarily make decisions now on a moving target because these clinical trials are changing and the phases change and maybe different trials are coming up as well.
This is why we try to open as many trials as we can, as long as they're not competing, and we try to open as many as we can to have them available for our patients and to always have options for our patients.
So let's talk a little bit about that. I know you mentioned that at the beginning about some of the trials you have. What are some of the trials that are open that you have that you're excited about that you think the neuroendocrine tumor patient community should know about?
We have the small cell lung cancer trial that is dotatate targeting.
And what's the drug that's being used for the small cell?
It's Lutathera for small cell lung cancer. It's amazing. Before this trial, I didn't think that small cell lung cancer can express somatostatin receptors. The basic teaching that we teach our resident is the opposite of that. I don't know how even they thought about it. Most probably it was a mistake, because some good ideas was just because of an error. A patient was delayed because the prior patient was delayed, and then I get the 60-minute uptake, and then, oh my God, this is really beautiful. Why did we do 60-minute uptake? This is really beautiful. Let's do this study. Sometimes you don't think about it, but then something happened, but like a mistake.
It's actually a lutetium trial.
This is called Lung 129, LUN 129.
So you're excited about PRRT and small cell, which is unusual. It was not previously thought of. And then you mentioned the alpha actinium trial.
We have a lead-212, DOTAM. It's an alpha trial, because we have trials that are targeting multiple tumors. Because now there are targeted therapies that target multiple tumors. We have 2 trials that have 2 radiosensitizers.
Looking at the landscape, you have trials open for different types of neuroendocrine cancer, including small cell, which is different than what was once thought. You have radiosensitizers, you have alpha. What are you most excited about, Dr. El Khouli?
Everything. I'm excited about everything. This whole nuclear medicine thing is just absolutely exciting. Can you imagine what's happening in nuclear medicine world right now? It is absolutely amazing. All these trials, at some point, going to make it to the clinical. Can you imagine? All these trials are going to be in our clinical world and are going to be available to our patients. Just thinking about that blew my mind, that we will be able to treat our patients and have all these options available for our patients to pick from. It's amazing. Of course, hopefully all of them work, and maybe a combination of them at some point, if we can combine them, and thinking about the synergistic effect of combining maybe pharmaceutical therapies to get more potent effect. And sometimes they think about shortening. For example, the Pluvicto is every 6 weeks, not every 8 weeks. They're trying to hit it and then hit it again quickly, and hopefully this will cause a better effect. So all these thinking and all these strategies, both of them are lutetium-177, so it's the same half-life. So why 6 weeks, not 8 weeks? Of course, there is the effective half-life, which is different than the physical half-life. It takes into account the biological half-life. So there is the physical half-life of the radioisotope, and there is the biological half-life. How fast does the body eliminate the product? How fast does the radioisotope decay? And how fast does the body eliminate the product? Both together give you the effective half-life. So it's very exciting, all these trials that we are involved in. And this is not all the trials that are available. I mean, these are the ones that I have here. In my list here, I have 20. There are much more out there that we're trying to get in. And I mean, there's so many trials. Just having all these options for cancer treatment, that's so exciting. Plus immunotherapy. I read PET CTs, like last week, I think Thursday maybe. I was reading a squamous cell carcinoma patient. Patient had 3 cycles of combined chemo and immunotherapy. Oh my God, we are in an era that is amazing, where we have options for patients, for treatment, for cancers that were very aggressive and killing patients. And now we have options. It's amazing.
It's amazing. I mean, thinking back, right, you've been doing this for a decade. You said even before the gallium-68 dotatate was FDA approved in 2016. So in the last 8-9 years, think about how far we've come. And now you have 20 clinical trials in just this area and where we can go from here. So much has happened. You're involved in this. So if you had a magic wand, where do you think we might be in 5 years from now? Where do you hope?
I hope we can really completely treat it. We can have a treatment, if some of these treatments can be offered early on in the disease, where we can completely really clean the disease, not applying it late in the disease, where all we can do is palliative and improve the survival a little bit. And I really wish we can do that. Maybe because I am in a center where we see a lot of patients, I feel that we are much more aware of the neuroendocrine tumor than 10 years ago or 20 years ago. I feel that we are aware of it. Don't you feel so?
Yeah, there's more awareness.
You guys are doing a great job. I feel that everyone is aware of the neuroendocrine tumor now, and I feel that we are finding it earlier than what we used to.
It feels like that, right? The number of people living with it is going up.
Which means we're detecting it much earlier.
So detecting it earlier, more people living with it longer.
Absolutely. So hopefully we can do a better job. So instead of patients living with it longer but suffering, I'm hoping that we can apply these treatments early on, where we can take care of the disease so it's not static and the patients are suffering for a long time.
As you mentioned several times, it's quality of life that matters, and it matters to patients. You want people to suffer less, enjoy the things that they need to more. What final words of hope do you have for patients?
Absolutely. There's a lot of hope. I mean, all these trials and all this work, absolutely a lot of hope. We have much, much more hope than before. Definitely.
Yeah, there's reason for hope. And you're contributing to that hope. Thank you so much, Dr. El Khouli. It's amazing how much you've done in this decade, and we look forward to seeing so much more.
Yeah, I had a lot of fun, and it was a great conversation. Thank you so much.
We really appreciate all your hard work in this area, and we look forward to hopefully together continue to raise awareness, impact quality of life, and stamping out this disease together.
Yeah, hopefully we are defeating that disease.
Thanks for listening to the LACNETS podcast. Go to our website, lacnets.org/podcast for episode transcripts and resources. We want to thank our podcast supporters, Ipsen, ITM, Crinetics, Curium, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to www.lacnets.org. LACNETS depends on donations to bring you programs such as this podcast. Please consider making a donation at lacnets.org/donate.